So for gas exchange, we just recently concluded this last week. For PE, ARDS, respiratory failure, any question on pathophysiology? So what happened? Is a PE an infarction? This is still caused by a clot. Is this an infarction?
It's not an infarction, but it should be common. It's a
No, it's not an infarction.
It's not an infarction.
Because it's not.
I know it's not.
It's an occlusion.
Is it an infarction or not?
What would say because it's dead.
Did the pulmonary arteries being blocked kill the lung tissue? So therefore, is it an infarction? No, it's not an infarction. Because why again? Do the pulmonary arteries perfuse lung tissue?
No.
No, because what kind of blood do they carry? So they can't be perfusing lung tissue. Where do lung tissues get their oxygen again? From the bronchial arteries, which come from where? From the, where do you find the bronchial arteries? They branch out of the thoracic aorta. Okay. So risk factors for PE, do they vary from DVT? Okay, so you notice where did we see PE? Was it in the respiratory chapter or in the vascular chapter? Under vascular disorders, right after DVT. Okay, so they consider this a vascular disorder. At least this textbook does. Other textbooks, other authors still put this together with respiratory failure and ARDS. I understand why the author chose this because technically it's a pulmonary embolism involving the pulmonary artery. So yes, technically it's a vascular disorder.
The diagnostic test for that was the VQ, right?
Remember the VQ is not standard because it's more expensive. So VQ scan is only reserved for when?
AKI patient.
Okay, so if a patient, because the gold standard is what? CT, right, CT angiography, which uses an IV dye. What is a contraindication for that again? Okay, patient has kidney injuries, they can't have that test, so therefore we have to use the VQ scan, or also called.
Where they give the radioactive gas and then.
Correct. Right. So that's the proper term, official term is ventilation perfusion scan. Again, don't ask me why they don't use VP, they use VQ, ventilation quotient. What about for signs and symptoms? Were they specific to PE? No, they were the same signs and symptoms as heart failure, right? Heart failure patients, COPD patients. So is it specific? No. So do we know when a patient comes into the ER that this is PE? No. So we test for everything. We do EKGs, we draw blood for, what is the blood test that would help us? No, that's for ARDS and D-dimer, okay? And then of course, do we draw troponin? Do we draw BNP? Okay, and then you said we draw also ABGs. Okay. What about for respiratory failure? What is the basis? How do we know the patient is in respiratory failure? What did we draw? And what did those ABGs show? Less than what? You said less than 60.
CO2 greater than 50, pH less than 7.75.
Very good, children.
The SAT is
Less than 90. Very good. So respiratory failure patients, just like PE, are there specific signs and symptoms? No, they look like anybody who has those ABG results, which is, are they cyanotic? Yeah, I mean, you PaO2 60, of course you're cyanotic, right? Are they short of breath?
Yeah.
Do they have mental status changes? Okay. Are they using accessory muscles?
Yeah.
Okay, very good, children. Do they respond? What's the only treatment for respiratory failure? And then the rest will be managing what? the underlying cause. Remember, respiratory failure do not come in with just respiratory failure, because is respiratory failure a primary diagnosis?
No.
It occurs as a consequence of, what are those causes again listed in the textbook? Okay, so there was a whole list of, are they all pulmonary causes? No, there were non-pulmonary as well. So did we see Guillain-Barré syndrome there? Did we see myasthenia gravis, spinal cord injury? Okay, all right, very good, children. And what's the only treatment?
Oxygen.
And managing the, do they respond to oxygen?
No. Yes, they do.
Yes, respiratory failure responds to oxygen. If, let's say, this respiratory failure patient does not respond to oxygen, is it still respiratory failure?
No.
It's now called
ARDS.
ARDS. Very good, children. Okay, so what is ARDS? So what's the number one cause under pathophysiology? What's the number one underlying problem? Acute lung injury. So acute lung injury is either direct or indirect, correct? So what is the problem? What if you develop acute lung injury? What happens? Why do the patient's lungs fill with water? Of the, okay, very good, because the capillaries are leaking. We call that capillary leak syndrome. So they become very permeable to large molecules. So not just water comes out, but debris like albumin, okay, large molecules, glucose, albumin, which are very huge molecules, come out of the capillaries. So of course, water follows those, and then that's why the alveoli fill with water. How do we know? What are the criteria for ARDS? X-ray will show what? No, don't check. No, that's trauma. That's chest trauma. It's ARDS first. Okay, they're wet, right? So they look, what's the color of the lung on X-ray? It's supposed to be black, but now because they're all wet, it's now white. So on the NCLEX, because the book didn't mention this, it may say white out appearance. Okay, white out appearance, that means ARDS. Okay, there's no other term for it. White out appearance or ground glass appearance. You know what is ground glass? You know, when you ground glass, yeah, you powderize glass, regardless of what color that glass is, green, violet, purple, when you ground glass, what's the color? White. Okay, they lose the color. It's all now white. So that's what it looks like on X-ray. So if you see the term white out appearance or ground glass appearance, that's all referring to what? ARDS. What else? How do we know it's ARDS? Because if a heart failure patient, a left side heart failure patient is admitted, you put an X-ray on them, ARDS patient here, heart failure patient here, what will their lungs look like? The same. Both look white. How do you know this is ARDS? This one's heart failure. How do we distinguish? Remember there was a term, and I showed it to you.
Stiff.
Yeah, it's stiff, but remember the term, it's talking about the right atrial pressure? You remember that? Oh, wrong text. Sorry. Okay, remember this part? So is there increased hemodynamic pressures? When I say hemodynamics, what are we talking about? Pressures inside the heart. Okay. So you said when I asked you last week, so what caused the pulmonary edema and heart failure? Why did water fill the lungs in heart failure? Backflow, because what's happening in the chambers and the pulmonary arteries and veins? There is? Because why did they backflow? Because there is congestion, right? Congestion of blood. So did that force that water out? Yes, the water was pushed out by increased capillary membrane permeability. Did the capillaries become leaky in heart failure? Where did it say that? No, there's no such thing. No. What's the problem? Congestion again. So the hydrostatic pressure. So the water pressure pushed that water out of the blood vessels, out of the capillaries. That's what happened in heart failure. So therefore, if you measure the, of course, we need a pulmonary artery catheter for this. So if you measure the chambers of the heart, the pressures, what happens to the pressure? Is it high, low, or normal? High, just a little high, or very high? Very high. Right here, there is the absence of elevated left atrial pressure in ARDS. Why? Again, you're talking about tension pneumothorax. So this is caused by, is this caused by heart failure? ARDS? No. There is no congestion here. What again caused the water to fill the lungs? Hydrostatic pressure is with heart failure. Okay, so the congestion leads to increased hydrostatic pressure, literally pushing water out of the bloodstream, putting it into the alveoli. Here, what's the cause here? The alveolar damage. So this acute lung injury here triggered the increased capillary membrane permeability. Remember septic shock? So was there ARDS in septic shock? NDIC? Yes, right? So we saw that there because what happened in septic shock? Was there increased capillary membrane permeability?
Yes.
Was there capillary leak syndrome?
Yes.
Same exact mechanism here. Okay, so acute lung injury, which again, we have a long list of acute lung injury, pulmonary and non-pulmonary causes. So this is what we mean by there is pulmonary edema, but is there increased hemodynamic pressures? No, there is no congestion. So that's how the doctors can tell, is this pulmonary edema from ARDS or from heart failure? Okay, so they compare, they measure the hemodynamic pressures, they measure the left atrial, right atrial pressure. It's normal or even low. All right. Any question on this part? Low or normal? And what is it in heart failure? Very high. So we have a whole chart causing acute lung injury, chart 19-20 right here. These are all your causes here. See, sepsis is here. Okay, so sepsis leads to ARDS. Did you not see this also in burns?
Yes.
Remember burns? Okay, so burns does exactly the same thing. Right, burns also cause increased capillary membrane permeability. So it leads to ARDS as well.
During a test question, it would be like, what can cause arms like that?
Or I could ask you findings. Let's say select all that apply questions. Which of the following are diagnostic findings in ARDS? Where would you find the answer? Right here. These are your diagnostic findings, ARDS. Patho, clinical manifestations, and your there. So will there be, let's look at the BNP levels. What is BNP again? Okay, so it helps us diagnose heart failure. What will be the BNP levels in an ARDS patient? High, low, or normal?
So it's like heart failure. Heart failure can cause it, so.
Yeah, but it's not. Hard.
Yeah, it's not.
Oh.
So Tyree, what will be the BNP level in an ARDS patient? Or low or normal? Because again, is ARDS caused by heart failure?
No.
No, not at all.
Also, that would be a good way to also see if it's heart failure or.
Exactly, right. So while you're doing all the testing, right? So you draw all those blood. We drew BNP, we drew what else? D-dimer, we drew a troponin, right? And then chemistry, of course, chemistry, CBC, and then this will help the doctor make a quick decision, right? Rula, BNP is normal, can't be heart failure. Okay, that's the first thing. BNP is normal or low, heart failure is out of the question. D-dimer's high. So therefore, what could this be? Patient comes in with ARDS, D-dimer's high. D-dimer's high. So therefore, you said there's a clot. Because look at the one of the causes of ARDS. Isn't it PE? PE was one of the causes listed here in ARDS. Where is it? It says fat or air, but you can include PE there, pulmonary embolism. All right. So please read those in detail. So do that for each one. Do that for PE, ARDS, and respiratory failure. Whether the hypoxemia or hypoxia is caused by heart failure, a PE, pneumonia, COVID, whatever, do they look different? Every hypoxemic patient looks like what? Earliest would be acute confusion or decreased level of consciousness or change in the mental status. That's the earliest. And then the rest you guys say would be dyspnea, cyanosis, and accessory muscle use. What's the treatment for PE? So we talked about 3, right? And there were lots of anticoagulants. We already know about alteplase. Who gets alteplase? What type of PE? All PEs in a different chapter. Chapter 26. So in PE,
unstable.
we also call that massive PE, right? Massive. So here, so if we have massive PE, because they are hemodynamically unstable. What do we mean again when a term says hemodynamic? What are we always referring to when we say hemodynamic? pressures inside the heart chambers, which can only be measured by what instrument? Pulmonary artery catheter. Remember Swan-Ganz catheter? And then the rest of the non-massive PE patients, because massive PE patients go into cardiac arrest, correct? So we do BLS, ACLS, and then for the rest of the majority of the PE are either low risk or submassive PE. What's the only treatment for those? Anticoagulants. And then the choice, of course, will depend on their risk factors. So the doctor would choose. So review our discussion on the anticoagulants. So you have a whole chart here. Or is it? Oh, no, it's not under here. It's under DVT. Yeah, I forgot.
26-.
Correct. So these are the... Oh, I didn't know there was a chart for... Remember the Virchow triad? The 3 conditions that lead to clot formation. Okay. So what can you also call this chart? Risk factors for what? DVT and PE. So therefore, if I ask you about prevention, okay, so you manage these. Okay. All right. So that's for risk factors for PE. And where's the anticoagulants again?
Table 26.
Okay, very good, children. So we discussed this, right? We watched the video. We discussed how each one works, what the antidotes are. For anybody on anticoagulants, what's your nursing responsibility? Okay. Preventing bleeding. And can we absolutely prevent it? No. So if we can't prevent it, at least we will. Well, we have to know first, besides antidote, we have to know whether or not they're bleeding. So how do we know they are bleeding? What are those findings? Well, it's easy if we can see it, right? So we can have the ecchymosis, petechia, and what's the color of the stool? If it's upper, or if it's lower, bright or dark red. How about emesis? If it's older, it will look coffee ground. Anybody know what coffee ground looks like?
Yeah.
Yeah, nothing like chocolate. Teaching, of course, you teach. What would you teach a patient after a PE? Are they immune? Sir, you've had a PE. You don't have to worry about it anymore. You already had it. Congratulations. What do we do? Okay, so you teach them okay, same risk factors. So do you educate them about the Virchow triad chapter? Chart 26-2, yes. And then precautions. Precautions will also include precautions for bleeding, okay? Because you know a PE patient is given anticoagulants. And we discussed this last week, how each drug works. Nursing responsibilities, this will not only be about monitoring. So let's recap. Monitoring for heparin. What do we draw? What blood? About for warfarin?
I know.
What's the antidote for each? Please take note if fresh frozen plasma is there, that's also for warfarin, okay? Yeah, we typically get that order if the INR is really high, meaning we can't give 50 milligrams of vitamin K. I mean, we can't do that. So we have to resort to plasma, which is more efficient.
Do we have to know the antibiotic suspension?
Yes, there's only one
Yeah.
antidote, so there's not much to memorize. There's only one that has either ruzizumab, something like that. Just read it. You recognize there's nothing else that sounds like dabigatran. Yeah. The foods, because this is teaching. So what are those foods again? That are okay, that's correct, but are they all leafy though? Because remember, cauliflower is not green or leafy either at all. Broccoli is green, but it's not leafy at all. Those are high in vitamin K as well. Then teaching. So for chest trauma, please stick with these signs and symptoms, manifestations. And we did the chest tube already. So it's maybe 1 or 2 questions on chest tubes.